Yeah, Room, thank you for giving me the opportunity to debate with you, my good friend, nice colleague. So again, a challenging situation to debate with a kind of very nice colleague. But let's go ahead and kind of argue for maintenance should be given only for 2 years. Just kind of to start maintenance therapy, some comments. And I want to remind you that the purpose of maintenance therapy is to prolong the duration of the remission and the life expectancy. This requires periodic follow-up monitor visits for kind of, to monitor toxicity and also response. If you have patients on Revlimid, lenalidomide, for instance, those patients have to come in monthly at least to check the CBC and also to see whether they are still responding and don't have a relapse. If this is lifelong, that's a huge burden for the patient, also for the doctor. In order to be eligible or to start maintenance, patients must have a disease in remission. It should be kind of, undetectable or at a low level, and they should recover from all previous toxicities. This is especially relevant for transplant if we have patients who receive the transplant and start maintenance with lenalidomide. So the maintenance agent should have a minimal toxicity or at least no overlapping toxicity with induction regimen. It should be convenient in the dosing and also convenient in the route administration. I think that carfilzomib is a challenging drug to give as a maintenance treatment based on the frequency and the type how we administer this. So but what are the problems with maintenance therapy? Since the induction therapy followed by autologous stem cell transplant alone will cytoreduce, but very often not kind of cure or kind of bring patients in a complete remission, there are open questions. For instance, what can maintenance achieve? Can it really prevent disease progression, and can it convert a partial response into a complete response, and does maintenance really improve overall survival? There are also other problems with maintenance therapy, such as everybody gets the same drug. We don't even know who is benefiting from the drug. There are patients who stay in their remission without maintenance. You burn an effective drug sometimes. There's treatment fatigue. That means not only fatigue due to treatment, but the patients are tired of coming in weekly for their maintenance treatment and also for the checkups. And also, what is the ideal maintenance strategy? Have we defined already the strategy that significantly improves the outcome with minimal side effects and preservation of the response? So those are open questions. This slide shows you a number of thalidomide maintenance trials. You can see the patients included a high number of patients, so large trials, up to 800 patients. Here, the trial from Gareth Morgan. Interestingly, you can see that giving thalidomide as a maintenance is kind of, increases the progression-free survival in all trials, there's no doubt. But looking for the overall survival, you can see that most of the trials who gave the maintenance did not increase the overall survival. Another trial using lenalidomide maintenance is a trial from the IFM, from the French group, the 2005. After stem cell transplant and consolidation with 2 cycles with lenalidomide 25 milligrams, the patients were randomized to a placebo arm or to lenalidomide. And you can see that the progression-free survival was significantly different in patients, or better for patients who received lenalidomide. It increased from 24 months to, from 24 months to 41 months. So this was highly significant. Looking for the overall survival, you don't see differences. The curve kind of, are completely the same. So showing that the overall survival cannot be increased with the maintenance. But looking for adverse events, and I apologize, kind of, the small typing, but it shows you that neutropenia increases from around, I think that's 18% to 50%. So 50%, half of the patients have grade 3-4 toxicity in the maintenance trials. And I would like to remind you, because we argue not about maintenance, yes or no, we argue about the time, that those side effects increase with kind of, continuous treatment. Looking for the kind of, heavily discussed second primary cancers, yes, there are increased number of hematological cancers in the group, kind of, that received lenalidomide. You can see that here. It increases from 5 to 13%, especially the hematologic malignancies, and we are focusing on this. So in conclusion, the French trial, the lenalidomide maintenance after transplant significantly prolonged the progression-free and event-free survival. But 4 years after the randomization, the overall survival was similar in the 2 study groups. So another trial from North America, the CALGB trial, which was headed by Phil McCarthy, randomized patients who had at least a stable disease after melphalan 200 and an autologous stem cell transplant to placebo or lenalidomide. Lenalidomide was given 5 to 15 milligrams according to the tolerance of the treatment. And again, what we expect and we saw before in the French trial, the progression-free survival was significantly higher in the patients who received lenalidomide with 46 months in comparison to 27 months in the placebo group. The overall survival was also increased in the patient who received lenalidomide, but you can see that despite this was significant, the difference was much smaller. Only 8% had a benefit from the lenalidomide. But you achieve this and you have a lot of hematologic toxicity. You can see that neutropenia, thrombocytopenia, lymphopenia, anemia was all significantly more often in patients who received the lenalidomide. And again, you can see that the grade 3/4 toxicity increases from around 15% to over 50%. Also, the secondary primary cancers increase in patients who received lenalidomide. This is from Phil McCarthy from the paper, and it shows that the risk to have a secondary cancer in case you received lenalidomide significantly increases in comparison to the placebo group. So in conclusion, also this CLGB trial from Phil McCarthy showed that patients who received stem cell transplant and maintenance with lenalidomide or placebo had an improved progression-free survival and also slightly increase in the overall survival in the lenalidomide group, but that was at the expense of the increased hematologic toxicity and also second malignant tumors. So this slide summarizes what I mentioned already, especially of toxicities. You can see that both trials shows an increase from around 15% to 50% hematologic toxicities. Also platelets increase from around 5 to 15%, and there's an increase in secondary malignancies in patients who received lenalidomide. Here again, a summary of the results of the efficacy of both trials. There's no doubt that there's an increase of the progression-free survival in patients who achieved maintenance. But if you look for the overall survival, you can see that there was no difference in the French group and a slight difference in the group by Phil McCarthy. So another trial from Antonio Palombo, the GEMMA trial, used 400 patients. I apologize again, it's a small writing, but you have to believe me, this is 399 patients, and they were randomized to transplant or the MPR non-transplant arm, and both groups later were randomized again into a lenalidomide maintenance group and took no maintenance group. And what that slide shows you again is similar to what I showed you before. Again, there is a significant increase in the progression-free survival in patients who received maintenance. But if you look for the overall survival, there's no difference in the 3-year overall survival in patients who received lenalidomide maintenance and no maintenance. Again, what we saw is an increased number of the grade 3/4 toxicities, as you can see here. And in conclusion, lenalidomide maintenance as compared to no maintenance after high-dose melphalan or MPR continuously prolonged the progression-free survival, but not the overall survival. So Dr. Palombo also focused with the maintenance a lot on the topic of the second primary malignancies associated with lenalidomide. And I just want to remind you that he analyzed patients who had an experience with solid tumors and also hematologic malignancies. And you can see that there are significantly more hematologic malignancies in patients who received lenalidomide. There was not a striking difference in patients in terms of solid tumor occurrence. But if you look through the subgroups and especially look what are the co-treatments, you can see that the combination of lenalidomide and melphalan as an oral regimen significantly increased and impressively increased the risk of secondary hematologic malignancies. I think this is important to keep in mind if we talk about maintenance. That's also important to choose the right and the correct maintenance. So in summary and the conclusions, I think I showed you that maintenance with novel agent significantly improves progression-free survival, and that maintenance after transplant did not significantly increase the overall survival in most of the randomized trials. Hematologic toxicity issues are critical, and also we have still a problem with hematologic secondary malignancies, which are increased after lenalidomide, especially in the combination with melphalan. So there are potential risks with continuous maintenance treatment. So the adverse events related to long-term treatment reduce the quality of life of patients. It impacts the subsequent therapeutic options, and the continuous follow-up of visits and also lab work increases the cost, and it's very time-consuming for the patient and also for the doctor. So there are other problems. Maintenance can possibly reduce the survival after relapse. Do we exactly know, that this has not an impact on survival at all? Maybe we can select, or maybe we select resistant clones. And it is also necessary that we have non-cross-reacting agents after lenalidomide. So we have to keep in mind that we expose all patients to the side effects of prolonged treatment, and there might be a cost explosion without proven benefit and for survival. So that's why I think we should limit maintenance therapy to 2 years. I think that it's common wisdom that dictates that the progression-free survival itself cannot be the only marker. I think I'm running out of time. So that the progression-free survival cannot be the only marker to really make the decision that you give lifelong treatment to patients. Perfect. Give lifelong patients to treatment without knowing that there's an exact benefit on the overall survival. Especially the quality of life, I think this is an important factor. If you give lifelong maintenance or give you lifelong maintenance until disease progression, keep in mind that those patients have high costs and also frequent office visitors, which is also important to consider. And I would like to stop, and Ruben, please go ahead.